Chapter 8, Drugs acting on blood and blood forming organs. Drug affecting coagulation and bleeding. Hemostatic agents. They arrest bleeding either by vasoconstriction or by promoting coagulation of blood. Classification. Hemostatics. Two types: local agents, systemic agents. Local agent: astringents, adrenaline, thrombin, fibrin, gelatin, calcium alginate, oxidized cellulose. Systemic agents: vitamin K, fibrinogen, antihemophilic factor, adrenochrome, monosemicarbazole, ethamsalate, desmopressin. Local hemostatics. Styptics. These drugs are commonly used locally to control bleeding from capillaries and minute vessels. Example: bleeding following tooth extraction, abrasion, epistaxis, etc. Astringents. They precipitate protein locally in the bleeding site and control capillary oozing by solution of ferric chloride, tannic acid, etc. Adrenaline. It causes vasoconstriction alpha 1 and arrest bleeding. A cotton pad soaked in 0.1% adrenaline solution is applied on the bleeding site to control capillary oozing. Example: epistaxis, bleeding after tooth extraction, etc. Adrenaline should be avoided in patients with hypertension, congestive heart failure, arrhythmias, ischemic heart disease, and uncontrolled hyperthyroidism, as it may precipitate myocardial infarction or aggravate the existing condition. Thrombin. It is a freeze-dried powder derived from bovine or human plasma. It is used topically to control bleeding from capillaries. It can cause hypersensitivity reaction. Thrombin should not be injected. Fibrin. It consists of fibrinogen, factor 8, thrombin, calcium, and other clotting components. It is used to control bleeding during surgical procedure or as a spray on bleeding surface. Gelatin. It is an absorbable hemostatic and is available as a sponge or a film. It produces hemostasis by providing a physical meshwork on which clotting can occur. Calcium alginate. It is obtained from seaweeds. It is an absorbable hemostatic and is used to promote wound healing. Oxidized cellulose. It is an absorbable hemostatic. It should be applied dry so that it swells up and help in formation of clot. It is used to control bleeding from capillaries and arterioles where ligation is not possible. It may cause tissue necrosis, nerve damage, or vascular stenosis. Hemocoagulase. Hemocoagulase enzyme complex is isolated from venom of Bothrop atrops viper. It has a powerful hemostatic effect. It promotes coagulation by converting fibrinogen to fibrin. It can also shorten bleeding and clotting time, thereby reducing blood loss. It is available for topical, intravenous, intramuscular, and subcutaneous administration. Systemic agents. Vitamin K. Vitamin K, a fat soluble vitamin, is required for the synthesis of clotting factor 2, 7, 9, and 10. Vitamin K exists in different forms. Vitamin K1, phytonidazole, fat soluble, is from plant and animal sources. Vitamin K2, menaquinone, is produced by intestinal bacteria, whereas vitamin 3, menadione, fat soluble, salts are water soluble, is a synthetic form. All three forms of vitamin K, K1, K2, and K3 are naphthoquinone derivatives. Derivatives. Dietary source. Vitamin K is found in spinach, cabbage, cauliflower, and tomatoes. It is also present in butter, meat, milk, liver, and pears. The average daily intake for an adult is estimated to be 70 to 140 mcg per day. Pharmacokinetics. Vitamin K1 and menadione require the presence of bile for their absorption. Vitamin K is transported along with low density lipoprotein and is stored mainly in liver. It undergoes glucuronide conjugation. Metabolites are excreted in bile and urine. Action. Vitamin K acts as a cofactor for gamma carboxylation of glutamic acid residue of clotting factor 2, 7, 9 and 10, and osteocalcin bone protein which is important for bone development. Deficiency. Vitamin K deficiency may occur due to inadequate absorption, lack of bile salts, loss of vitamin, chronic diarrhea, and administration of broad spectrum antibiotics, suppression of bacterial flora. In vitamin K deficiency, there is an increased tendency to bleed, epistaxis, hematuria, gastrointestinal bleeding, and postoperative bleeding. Preparations. Phytonadione, vitamin K1, it is available for oral, subcutaneous, intramuscular, and intravenous administration. Menadione sodium diphosphate, vitamin K3, it is a water soluble preparation and is available for IV, IM, and oral administration. Menadione and its water soluble salt have low efficacy and are toxic, hence, they are not commonly used. Uses. For prevention and treatment of bleeding associated with vitamin K deficiency. First, in obstructive jaundice with hemorrhagic symptoms, parenteral vitamin K1 is preferred. It is also administered to treat vitamin K deficiency resulting from prolonged antimicrobial therapy. Vitamin K1 1 mg phytonadione IM is given routinely to all neonates to prevent bleeding as the intestinal flora, which is necessary for the synthesis of vitamin K, is not developed. Third, to control bleeding due to oral anticoagulant therapy, vitamin K1 is used. 4. Vitamin K1 is used in salicylate poisoning with hemorrhagic complication. Adverse effect. Oral vitamin K is safe. Intravenous injection may cause flushing, sweating, dyspnea, cyanosis, collapse, and an anaphylactic reaction. Menadione may cause hemolysis, hyperbilirubinemia, and kernicterus in newborn. Fibrinogen. It is obtained from human plasma. It is used to control bleeding as associated with hypofibrinogenemia and is infused intravenously. Antihemophilic factor. It contains coagulation factor 8 with von Willebrand factor. It is used to control bleeding episodes in hemophilias. It is administered as IV infusion. Adverse effects include fever with chills, headache, and skin rashes. Adenochrome monosemicarbazole. It is available for oral and parenteral administration. It is used to control capillary oozing following tooth extraction, epistaxis, hematuria, etc. Ethamsalate. It is a hemostatic available for oral and IV administration. It corrects abnormal platelet adhesion and also maintains the stability of the capillary wall. It is used for prophylaxis and to control bleeding from small blood vessels. Example, menorrhagia, bleeding following tooth extraction. It may cause skin rashes, hypotension, and headache. Desmopressin. It is a systemic analog of vasopressin. It is used to control mild to moderate bleeding in hemophilia A and von Willebrand disease. It is intravenously slowly infused. Anticoagulants. Anticoagulants are drugs that prevent or reduce coagulability of blood. Classification. First, used in vitro are A. Heparin, B. Sodium citrate used in blood banks to store blood, C. Sodium oxalate, D. Sodium edetate. Both are used as an anticoagulant in the laboratory. 2. Used in vivo. A. Parenteral anticoagulants. First is indirect thrombin inhibitor, heparin, UFH, unfractionated heparin. Low molecular weight heparin, LMWHs. Enoxaparin, dalteparin, tinzaparin, adreparin, reviparin. Synthetic fondaparinux. Second, direct thrombin inhibitors, lepirudine, bivaluridine, ergotroban. B. Oral anticoagulants. First, coumain derivatives, warfarin, dicumarol, acinocumarol. 2. In indadione derivatives, phenindione. 3. Direct thrombin inhibitor, dabigatran. 4. Factor Xa inhibitor, rivaroxapaxin. Parenteral anticoagulants. Indirect thrombin inhibitor. Heparin, unfractionated heparin. Heparin was discovered by a medical student MacLean. It was later isolated and identified by Howell as a sulfated mucopolysaccharide, a strong electronegative compound. It is the strongest organic acid in the body. Commercially, heparin is obtained from ox lung and pig intestinal mucosa. Mechanism of action. Heparin via a pentasaccharide sequence and forms a complex with plasma antithrombin 3 activating it. This produces a conformational change in antithrombin which accelerates its binding to clotting factor 10A, 2A, 9A, 11A, 12A and 13A. Heparin antithrombin 3 complex inhibits activated clotting factor 10A, 2A, 9A, 11A, 12A and 13A. To accelerate thrombin inhibition, heparin must bind to both thrombin and antithrombin. This is possible because heparin molecules are long. For inhibition of factor 10A, binding of heparin to antithrombin only is necessary without simultaneous binding to 10A. The latter binds to antithrombin. At low concentration, heparin selectively inhibits the conversion of prothrombin to thrombin. Heparin thus prevents further thrombus formation. Heparin in high dose has antiplatelet action and prolongs the bleeding time. Heparin releases lipoprotein lipase which hydrolyzes triglyceride resulting in clearing of lipemic plasma. Pharmacokinetics. Heparin is not absorbed after oral administration because of its high negative charge and large molecular size. Therefore, it must be given parenterally, intravenously or subcutaneously. On IV administration, the anticoagulant effect starts immediately, whereas through subcutaneous route it takes 1 to 2 hours. Heparin is highly protein bound. It does not cross blood-brain barrier or placental barrier and is safe during pregnancy. It is rapidly inactivated in the liver by heparinase and the metabolites are excreted in urine. Mode of administration. Heparin is usually administered by IV infusion for treatment or subcutaneous route if cannot be given as IV infusion or when given in low dose for prophylaxis. Intramuscular route may cause hematomas, hence should not be used. During heparin therapy, activated partial thromboplastic time. Monitoring is necessary and it should be maintained at 1.5 to 2.5 times the control. Adverse effect and contraindication. First, bleeding. The main side effect is bleeding. Overdosage may cause serious and fatal hemorrhage. Bleeding can occur in the urinary. Hematuria is generally the earliest sign, and gastrointestinal tract or anywhere in the body. Hence, heparin therapy requires APTT monitoring. No antagonist is required in mild bleeding as effect of heparin disappears within hours. If life-threatening hemorrhage occur, it can be controlled rapidly by slow intravenous infusion of protamine sulfate, heparin antagonist. It is a strongly basic protein and hence rapidly neutralizes the anticoagulant effect of heparin. Protamine sulfate, strong base, heparin, strong acid. Protamine sulfate is a specific heparin antagonist which is obtained from fish sperm. 1 milligram of protamine sulfate approximately neutralizes 100 unit of heparin chemical antagonism. Protamine sulfate itself may cause bleeding as it has weak anticoagulant effect. Hence, the maximum dose must not exceed 50 mg. 2. Heparin induced thrombocytopenia. Heparin rarely causes thrombocytopenia. It is due to formation of antibodies against platelet factor 4. Heparin complex leading to a decrease in platelet count. Thrombin complication can occur. The incidence is higher with unfractionated heparin than with LMWHS. Heparin should be discontinued. LMWHS cannot be used in such patients. Hypersensitivity reactions can occur rarely. They are skin rashes, urticaria, fever, etc. Osteoporosis. Dose dependent osteoporosis with spontaneous fractures may occur during long term therapy. Reversible alopecia has been reported. 6. Abnormalities in liver function test can occur. Heparin is contraindicated in hemophilias patient with HIT, severe hypertension, intracranial hemorrhage, bacterial endocarditis, active tuberculosis, peptic ulcer, threatened abortion, cirrhosis, renal failure, etc. Low molecular weight heparins. Enoxaparin, dalteparin, tinzaparin, ardiparin, reviparin, etc. are LMWHs and are obtained from standard heparin by fractionation. LMWHs produces anticoagulant effect mainly by inhibition of factor 10A through antithrombin as they are not of sufficient length to bind to both thrombin and antithrombin simultaneously. They have little effect on thrombin inhibition. Hence, LMWHS has less effect on APTT as compared to unfractionated heparin. LMWHS produces anticoagulant effect mainly by inhibition of factor 10A through antithrombin. LMWHS therapy usually does not require APTT monitoring, but patients with chronic renal failure may need monitoring by measuring factor 10A activity since they are excreted through kidney. The effect of LMWHs are not completely reversed by protamine sulfate. LMWHs are given subcutaneously. The following are the advantages of LMWHs. First, they have a higher subcutaneous bioavailability as compared to UFH. 2. They have a longer T-half, can be administered once a day. 2. They do not routinely require APTT monitoring. 4. There is a lower incidence of thrombocytopenia and osteoporosis as compared to UFT. Fondaparinux. It is a systemic parenteral anticoagulant. It binds to antithrombin and selectively inhibits factor 10A without an effect on thrombin. Fondaparinux is administered subcutaneously. It is used in pulmonary embolism and deep vein thrombosis. It has a long T-half of 17 hours and good subcutaneous bioavailability. Incidence of thrombocytopenia and osteoporosis is lower with fondaparinux. It does not require routinely laboratory monitoring. Its effects are not reversed by protamine sulfate. Fondaparinux should not be administered in patients with renal failure. Parenteral direct thrombin inhibitors. They bind directly to thrombin and inhibit it. They do not bind to antithrombin 3. Lepirudine. It is a recombinant hirudine. It is used as an anticoagulant in patients with heparin-induced thrombocytopenia. It is administered intravenously and require APTT monitoring. No antidote is available. Ergotroban. Ergotroban is a synthetic direct thrombin inhibitor administered by intravenous infusion. It is rapid and short acting. It can be used in patients with heparin induced thrombocytopenia. Monitoring of APTT is required during therapy. Bivalirudin. It has a mechanism of action similar to that of lepirudin, but its action is reversible. It is administered intravenously. Thank you.